Hi, my name's Julia Ware, and I am a clinical research associate and pediatric registrar, and I work at the University of Cambridge with Roman Hovorka on closed loop insulin delivery research in children and young people. And I've been asked today to talk to you about interpreting closed loop downloads. So thank you so much for inviting me to record this presentation for you, and I do hope you find it useful. These are my disclosures. So in this presentation, I'll be talking to you about my general approach to download review and how I look at the big picture and then the little picture, and then some tips for optimization across all the different systems. This is quite a short presentation, so I won't have time to go into details for optimization for each individual closed loop systems. In terms of the general approach to download review, I feel that structure is key. So if you have a system of how you look at the downloads, then that will really help you, regardless of which system it is that you're looking at. And I like to split that into the big picture and the small picture. And that's something that I sort of adapted from the BDC Panther program, if you've heard of that in the US. And they basically have developed cheat sheets for all the different closed loop systems using the CARES paradigm, which was a concept that Laurel Messer invented in the US, and it looks at each closed loop system, and it looks at the kind of main features of each system using the acronym CARES, where C stands for calculate. So how does the algorithm calculate insulin delivery? A is for adjust. What can you adjust in the closed loop system? R is for revert. So when should you revert to open loop? And also when does the system go into open loop? E is for educate, so kind of key tips and tricks for each system, or the key education points, quirks for that particular closed loop system. And then S is for sensor and share. So what sensors does the system work with, and what are the remote monitoring and data sharing capabilities? And using that acronym, you can really quite quickly and easily work out the differences between the systems. I think my main tip is use a cheat sheet, and there are several different ones available. So the Children and Young People's Diabetes Network has developed a technology comparison guide. The Omnipod is not yet on there, but I'm sure that's coming, and it's very good. Like I say, the BDC Panther program has developed resources for all the closed loop systems, except for CAM-APS-FX, because that's not available in the US. And they're all free to download. And I use cheat sheets too. I think as more and more systems come onto the market, it's, you can't possibly remember every little thing about every little system all the time. And it's absolutely fine to have a quick look at your cheat sheet before you see a patient in clinic, to remind yourself of the certain key features. And I would highly recommend. I know lots of clinics also develop their own. I feel that's sort of duplicating work, but whatever works for you, really. So moving on to the big picture approach when you first see the download. So the first thing that you really need to look at, and I think sometimes gets a little bit forgotten about, is data adequacy, because there's absolutely no point in going any further if you don't have adequate data to look at, because you can't spot patterns. And the minimum recommendation really is 14 days of data, where they've used the CGM for at least 90% of the time and auto mode for at least 90% of the time. If they're using CGM or auto mode less than 90%, then that's absolutely the first thing to address before you even look at the data in any more detail. You need to address with the person in front of you why they're not using closed loop, because it's not going to work if they don't use it. Once you've reassured yourself that there's adequate data for you to actually have a look at the download and gain any sort of useful information from it, the important thing is really your initial overview in terms of the big picture. So looking at your kind of traffic light, time and range, time below range, time above range. And I think also very important, the mean glucose, because that gives you a slightly better idea of where their HbA1c is going to sit than just time and range. And from that, you can very quickly glean, are they meeting glycemic targets as they stand? Are we very far away? Are we quite close? Is there lots of time in hypo, for example? And you'll immediately already probably have some ideas of things you want to focus on. Something to also look at that time is the glucose variability, so either the SD or the coefficient of variation, depending on what you prefer. And then the last thing to look at for the big picture, I think important, the automated insulin delivery to bolus split. And that is a bit system dependent, and I'll get into that in the next slide. So when you are looking at the landing page on Gluco, so that's for most of the systems apart from Medtronic, you see something a bit like this. And the way that I tend to go through it is I start with the traffic light, as I said, because you really can glean quite a lot of information from that quite quickly. So this young person has got a very high time in range, which is great, but they do seem to have 6% time below range. So that's a bit higher than we would like. And I can see here that the CGM is active 97% of the time. And if I have a look down here in system details, that's where I can see auto mode usage. So in this case, that's 85% of the time. So that's a bit lower than we'd like. So already I'm thinking, okay, we need to have a look at what's happening, why auto mode is off 15% of the time. And for CAM-APS, you can also see boost and ease off use in the system details window. For Omnipod, you can see auto mode use there, and then also when they've been in auto mode limited, which is basically auto mode off, except that the basals are sort of smart in that it calculates basals based on previous insulin use and whatever you've set as the backup basal, and manual mode use, and you can also see whether they've been using activity mode. And then for the T-Slim in the system details, again, you can see how much time they've been in auto mode, which here is called Control IQ. And then you can see how much they've been using sleep mode and exercise mode. So once I've looked at that, so how much auto mode use they're having and whether they're using additional features within the system, I then have a look at the basal bolus split. And here the nomenclature is slightly confusing, and I think down the line we would need to work on how to name these things, because what these terms mean is a bit different depending on what closed loop system you're looking at. So for CAM-APS FX and for Omnipod, all corrections are incorporated into the automated basal. So there's no auto corrections in those systems. It's all incorporated into the automated basal. And so here you're generally looking probably for a kind of 50-50 split between the automated basal and then the user-initiated bolus. For Control IQ, the basal is automated, but all corrections are given as auto corrections, and they fall into the bolus category. So you'll probably see a higher bolus proportion if someone's using Control IQ well, perhaps a 40-60 split or even maybe a 30-70 split, depending on how many autocorrections they're having and how much they're bolusing. In the under sixes, I would generally say that you are looking at a 30-70 split, and that is regardless of systems. And that's because in that age group, the percentage of total daily dose that's given as bolus is very high, and it needs to be to really get optimal outcomes. So you're usually looking for a sort of 30-70 split, but at least a 40-60 split, even with something like CAM-APS FX. And then, of course, you can also see the number of boluses they're giving a day, which will give you an idea of whether they're bolusing enough and also whether perhaps they're working quite hard like this person is. And then the last thing I look at if you've got time down here on this side is the carb entries. So again, just gauging whether the grams of carbs entered sort of match what you'd expect for that particular age group. And I think I skipped over the AGP here. Of course, I look at the AGP, which gives you a nice overview over the 24-hour period. And you can glean very quickly, looking at the interquartile range, this light blue shaded area, whether the, generally values are quite tight in range and they don't have big variability. And you can, of course, also see where perhaps issues fall in terms of hypo and hyperglycemia. And it gives you a good idea of what you're perhaps going to focus on when you dive into that smaller picture. In the Medtronic systems, that is obviously via CareLink, and you would use your assessment and progress report here. And then this is kind of the main sort of first page that you get. And whilst it looks quite different to Gluco, it has all the same information. So you've got your traffic light system here, and you just need to remember whether the time period you're looking at is A or B. And then you've got all your sort of stats. So you've got SmartGuard, which is the name for auto mode for the Medtronic 780 and 672. And you can see here that auto mode use is quite high. You can see the sense aware percentage. You can see their average glucose, their GMI, their CV. Interestingly, and probably quite nicely here, you can see how many alerts they're getting a day, which is quite a handy feature. And then here we're looking again at the basal bolus split. So you can see here that there's almost 2/3 really as bolus and then 1/3 as auto basal. And really in the Medtronic, again, the auto corrections are incorporated into the bolus amount. And so you're looking really here for a sort of 60-40 split. So more bolus than basal. Because the auto corrections are incorporated into that bolus calculation, although Medtronic does give it to you separately as well. And then also quite helpfully, unlike in Gluco here, you can see actually how often they do a set change, which is quite a handy feature. And then for Medtronic, you can also see how often they've come out of closed loop and why. With the 780, it tends to be less of an issue. But that's where you would find that information. And then lastly, at the top, you've got your AGP again to give you that 24-hour overview. So now you've looked at the sort of big picture, and you can see that already you've been able to glean a huge amount of information. And normally I spend maybe 2 or 3 minutes on that, not a lot of time. And as you get familiar, you'll get quite quick at sort of snapshotting the different bits. And you've already got a really good idea about how things are going, how are they utilizing closed loop, what are perhaps problem areas you want to look at or problem times of day. And you really haven't spent a lot of time. But it helps you in terms of where to focus your attention when you dive into the little picture. So when you're thinking about the small picture, I think it's important to remember the basics matter. So are the basics in place? And these are really not closed loop specific things. These are sort of general diabetes management things that it is very important not to forget about, because it doesn't matter how smart your algorithm is, if the basics aren't in place, things are not going to work. So is the young person bolusing for meals? You will always get optimal results if you bolus for meals. And are they carb counting? Are they pre-meal bolusing? And we all, I think, know by now that closed loop systems are fairly unforgiving in terms of late bolusing. And that's because as glucose rises when the meal starts, the closed loop system will start delivering increased amounts of insulin, whether that's as autobasal or autocorrections. And if you then give the bolus late, you're bolusing into what's already quite a lot of active insulin, and you get this delayed hypoglycemia. The other thing that's really important to remember are backup basal rates. So it's very important to look at those every 3 to 6 months in children and young people, because they grow and they need different amounts of insulin. And when somebody comes out of closed loop, they need to be safe. And also some of the systems actually use the backup basal rates to make certain calculations when you're not in closed loop. So it's very, very important that those are up to date, and you need to look at those at clinic appointment. Looking at set changes in sites, I think we all go on and on about it, but if the insulin isn't going in properly, again, it doesn't matter how good your algorithm is, it's not going to work very well. And then sensor calibrations, this is thankfully becoming a thing of the past. So are they calibrating if it's required? Thankfully, the majority of people now no longer need to calibrate sensors. And then the last thing that's quite important is, are they suspending the pump when it's disconnected? So if they take it off for things like sports, are they suspending it? Because if they don't suspend it, the learning algorithms will continue to learn while the pump is not on their body, thinking that the insulin's going in when it is in fact not. And that will impact what the algorithm learns. So it's very, very important to suspend the pump when you disconnect for more than 15 minutes and to remind young people to do that. So when you're diving into the small picture, I would say that's the time to remind yourself about what's adjustable and in the different systems and sort of how they work. And that's when your cheat sheets will really come in handy. This is just something that I made, and it's not complete by any stretch of the imagination, but it's just a sort of way of thinking about it, I guess. And the most important part, perhaps, is the user adjustable settings. So what can you actually adjust in closed loop? What will make a difference to the closed loop algorithm? And that's quite different for all the different systems. and then also whether the preset basal rates influence automated insulin delivery, are there autocorrections, etc. So this is the time to look at your cheat sheet and just kind of remind yourself about these things, because that will help you to make appropriate suggestions depending on what problems you discover when you look at the small picture. How do I assess patterns? I think on gluco, the best way to do it is to use the day by day and the calendar view to look for patterns. So on gluco for FX, Control IQ, and Omnipod 5, if you go to the graph section at the top, and then I tend to leave it on 2 weeks, and I click on calendar, and then you get this quite nice view that you can see down there, where you can see your glucose data, you can see your carbs entered, and you can see any manual boluses that have been given. Down here you can see closed loop working, and then you can also, this is where for these 3 systems you can see set changes. So you can gauge quite quickly over that 2-week period whether they're roughly doing set changes every 3 days, just visually. And again, I can also glean quite quickly, are they in closed loop most of the time? Sort of how many boluses do they seem to be giving in a day? What are perhaps problem times of the day? So it's just quite a nice quick way to look at boluses, time in closed loop, set changes. And then the other way, once I've had a look at that, the next thing that I like to do is to set it to 1 day and to go to overview, and that's really when you can look at day by day. If you see a day on the calendar view that you think looks particularly problematic, you can also just click on that and it will take you to that day. But yeah, in the day by day view, then you can see just in much more detail what you can see in the calendar view there. And if you hover over things, you can see extra information. And that's the way then day by day to look at whatever part of the day you're perhaps picking up on is the area to look at, etc. For Medtronic, look at weekly review to see similar data, and again it will give you that sort of calendar view type picture where you can see boluses and whether they've been in closed loop, etc. And when you're looking at patterns, I think perhaps a way to think about it is to try and split it into different categories. So is there an issue at a certain time of day? And if it's at a certain time of day, is it overnight or when they're fasted, or is it in the daytime? Is it breakfast, lunch, dinner, evening? Is there a sort of a time of day that has an issue? Another category to think about is whether they go low or high after meals. So if they're going low after meals, are they either bolusing too much or are they bolusing late? If they're going high after meals, are they not bolusing? Is the carb ratio not right? Those are things to think about. And then thinking about what happens after they have a low. So after they have a high, sorry. So are they having lows after they have highs? Is that because perhaps they're giving a manual correction when they perhaps shouldn't be? Is it that in, for example, Control IQ, the ISF is set too strong and so the autocorrections are too big? Have a think whether that's perhaps a pattern that you see. Equally, do they tend to have high glucose after a low? So are they over-treating hypos? Are the problems exercise related? So is it always the same time in the week? And I've already sort of briefly touched on this, issues around manual corrections. I can't stress this enough. The most of the systems really are better left without manual corrections, unless you have something like a set fail or you're ill or some sort of unusual circumstance. So that's sort of a way to think about different patterns. And that's really the way that I would approach any system. And you can see already that actually the approach is quite similar across systems. It's really just the fine tuning that's different between the systems and what you can change. And that's what your cheat sheet is helpful for. So lastly, just briefly to touch on kind of tips for optimization. And this is quite general because I've kept it across systems. I think a very, very important part of the consultation with any young person and their family when they're on closed loop or any therapy really is to discuss expectations, because you might be going in there wanting them to have 70% time in range and less than 4% time below range, but that might not be what they're aiming for. And you can sort of talk about A when their agenda is B, and then things will just not match up. So I think making sure you discuss what their expectations are, how they feel things are going, what they would like, what they feel the problems are. It's so, so important. And bearing in mind as well that the whole point of closed loop is to make life easier. So we want to make sure we balance glycemic outcomes with sort of reduced management burden and improving quality of life. There's no point in having 80% time in range when all you're doing is diabetes. That was not the idea behind closed loop. So I think just really bear that in mind, especially if you see somebody who has really high time in range but is working very hard. And the other thing that we sometimes forget about, I think, in clinic is considering alarm burden. So again, on gluco, you can see that data if you go into the devices part. On Medtronic, it's a bit easier to see because you see it on the landing page. But just think about it. If they're getting tons and tons of alarms, it would be worth a conversation in terms of reducing that alarm burden. Across all systems, hypo treatment is a very important topic. When you're using closed loop, you tend to need less hypo treatment in general because most of the time the system has already suspended insulin delivery before you have the low. Exceptions to that are if you, for example, just given a big meal bolus recently. But generally, there's already less active insulin by the time you have the hypo, but you need to take insulin delivery in the last 90 minutes into account. So you need to have a look either at your pump or your phone screen. But for the many people, 5 to 10 grams of fast-acting carbohydrate might suffice. Obviously, you always need to consider the glucose value in the directions of the arrows. But in general, people need less hypo treatment. So if you're seeing big highs after a low, just bear that in mind. With closed loop systems, it's very important to optimize the carb ratios, and often different carb ratios are needed compared to when they were on pump therapy before or MDI. And in younger children, just as a reminder, the bolus insulin makes up the majority of the total daily dose. So it's even more important to get those ratios right and making sure their carb counting is good. If they're having hypos post-meal, or the algorithm-driven insulin delivery shuts off completely post-meal, it's likely that the carb ratio is too aggressive. And you can see an example of that here. So someone's given a bolus for breakfast, and then there's absolutely no insulin going in for the next 3 hours. And you can see that here, and still they have like a delayed low. And what happens then, of course, is they take some hypo treatment, and then there's been no active insulin in the system now, nothing going in for about 4 hours, and then they have a big rebound high, and it becomes really tricky to manage lunch. Similarly here, control IQ, you can see the big bolus for breakfast being given. The system then shuts off for most of the next couple of hours. They treat a hypo and they have this enormous rebound high and then spend the rest of the day trying to get back down. We all know that it's important to have a little bit of active insulin in the background at all times. And so what you really want to see is you want a little bit of algorithm-driven insulin delivery after that meal bolus. Not lots, but a bit. So if you see nothing or having lots of lows after the meals, that carb ratio is too strong. Conversely, if you're getting big rises after the meals and or the algorithm is really pumping in a ton of insulin to deal with that rise, often then increasing the risk of a delayed hypo, it's likely that your carb ratio is too weak. And you can see that here. So someone's given a bolus for breakfast, 2.6 units, and you can see then that the system has given a lot of insulin behind. So if you look over here, probably about 2.5 units per hour for a couple of hours. So double the amount of bolus has gone in the 2 hours afterwards. And you can see then here that there's a delayed hypo because of basically delayed insulin delivery because the bolus wasn't big enough for the meal. Thinking about late bolusing for all the systems. So in general, I would suggest that if they remember within 30 to 60 minutes of eating, giving about 50% of the bolus, because by that point, the full bolus may well cause a hypo, because the algorithm will have already increased insulin delivery. And if it's more than 60 minutes, it depends a little bit on the system. So in CAM-APS, you could use Boost. In Control IQ, it may well be that the system deals with it through an autocorrection. You could put on an extended bolus, which might be safer than giving a manual correction because you could stop it when glucose starts coming down. For the 670, your only option is probably a small manual correction. In the 780, it probably would be reasonable to wait and see if it manages through auto corrections. Otherwise, you might need to give a small manual correction. But as I said before, I would generally dissuade from that because it usually leads to hypos. And similarly, for the Omnipod 5, you're probably best off waiting and seeing what happens. And And then I think one of the last things is remembering to check the glucose target. So this doesn't pertain to all the systems because not all of them have this feature. So Control IQ, you can't really change the glucose target unless you put on exercise asleep mode. And for the 780, you can put on your temp target, and then you can put the 3 targets, but they're for the whole 24 hours. So it's a bit easier to see what's going on. But for Omnipod 5 and FX, you can have quite a number of different targets at different time points during the day. So it's just important to remember to check what those are. Because, for example, for FX on Gluco, you can't easily see it. So you need to go to Devices and then click on My Life Ipso Pump and then Pump Profiles. And then there you can see what the personal glucose targets are, remembering that for FX, the default's 5.8. And for the Omnipod, you can see down here that it actually shows you in the day-by-day view what the targets are set at different times of day. And the reason I'm saying this is that sometimes people very appropriately set a higher target when there's lots of hypos during a particular time of day or for a particular time period, but then everyone forgets to lower the target back down, and then we all wonder why that person's time and range has deteriorated so much. So just bear that in mind. And here's an example of the Medtronic. You can see the temp target here, but you can also see that through the day, the general target is set at, looks like 6.1, so the lowest possible. So it's a bit easier to see, but again, worth bearing in mind and checking. Lastly, exercise. So again, it's a bit system dependent, but there are some general rules for all the systems. In general, it's recommended to use a temporary increased target or activity mode to reduce the aggressiveness of the system. And ideally, you want to start that 90 minutes prior to the activity. And then if you're wearing the pump during the activity and perhaps after, depending on whether you're the sort of person who has hypos later on. And all the systems have some version of this. So everybody can use this. And the other important thing is to avoid pre-exercise carb loading. Because if we have something very carby and glucose starts rising, closed loop will start giving extra insulin. And what we really don't want for starting exercise is lots of active insulin. So you're really better off drizzling in carbs as required while you're exercising in very small quantities. For some people, suspending insulin delivery for a period of time is really the best option, and there's no shame in that. If that's what works best, that's absolutely fine, especially for kind of long duration cardiovascular exercise. And I think if you have somebody who's really sporty, taking the time or booking in an extra clinic appointment to really go through individualized planning is very important, because we don't want to put people off exercising. Managing alcohol, very important for our young people. Similar to the exercise, consuming a bedtime snack as a strategy to avoid hypos is probably not going to be helpful because, again, you'll have that rise in glucose and closed loop will pump in insulin. So what you should do instead is use some sort of temporary increased target. So for some of the systems, that will be confusingly exercise mode or a temp target or ease off, whatever that mode is. That would be useful. And you could put that on all night, really. I've heard somebody else at a conference call it party mode, which I quite liked. So just remembering to counsel young people on that, because that's quite different to the advice that we would give to somebody on a normal pump or MDI. What is the summary of this talk on downloads? I think don't panic. I know there are lots of different systems out now, but actually they have more similarities than differences, and you absolutely can get to grips with looking at downloads for all the systems. There are 4 systems now available, and I'm sure more will come. So this is not going to go away or change. But I hope I've convinced you that a general approach works across all the systems. You absolutely should use some cheat sheets. Make sure you discuss expectations with the families and balance those glycemic goals with management burden, because closed loop is supposed to make life easier. And the last thing I would say is ask the families about tricks they use. I often learn lots of cool things that people have discovered or that they do that work for them and that you can then perhaps apply to another patient with a similar issue. These are my acknowledgements. So I'd like to thank the team here, Adam Brooks, and of course, Roman Havorka and the Artificial Pancreas Group. Thank you so much for inviting me to give this talk.